Good evening, everyone. On behalf of the entire University Hospitals family, we'd like to thank you for joining us for our webinar on hip and knee pain in adults, its causes, non-surgical, and surgical options for treatment. My name is Rich Riley. I'm a proud member of University Hospitals Marketing and Communications team, and I'll be your moderator for this evening. I'd also like to recognize my colleague Kelly, who is also with us this evening, as she's assisted me in planning and conducting this event as well. A few housekeeping notes before we begin. In this platform, all attendees are muted. While you won't be able to ask questions through your microphone, please note the Q&A function at the bottom of your screen. If you have a question that is not addressed throughout the course of the presentation, please submit your question through the Q&A feature, and our presenter will address questions at the end of his presentation. Also, this webinar is being recorded and will be available for viewing on demand in the near future. It will be posted on our University Hospitals website, and as an attendee of this evening's presentation, you'll receive an email with a link to the presentation. It is now my pleasure to introduce our presenter, Dr. Stephen Fitzgerald. Dr. Fitzgerald is a board-certified orthopedic surgeon and serves as the director of adult reconstructive surgery at University Hospitals, specializing in arthritis, orthopedic surgery, reconstructive orthopedics, and total joint replacement and adult reconstruction. Dr. Fitzgerald also serves as an assistant professor of orthopedics at Case Western Reserve University School of Medicine. Dr. Fitzgerald attended and graduated with honors from Tulane University School of Medicine. He completed his residency in orthopedics at Case Western Reserve University Hospitals and his fellowship at the Mayo School of Graduate Medical Education in adult reconstructive orthopedics. Currently, Dr. Fitzgerald sees patients at UH Ahuja Medical Center, UH Medina Health Center, and UH Mayfield Health Center. Ladies and gentlemen, I'm proud to present to you Dr. Stephen Fitzgerald.
All right, thanks for the introduction, Rich, and thank you everybody for joining us tonight. So we're going to talk tonight about the common causes of arthritis and a little bit about treatment in the pre-surgical area before you get to be a candidate for a joint replacement, and hopefully answer some good questions for the second half tonight. So to start out, a lot of questions I get in clinic are just what arthritis is, but it's the most common reason that we do hip and knee replacement. But osteoarthritis is the most common cause or type of arthritis. And it's just really the cartilage cushioning of the bones of the joint wearing away over time. And the most common way that people describe this is what we call wear and tear arthritis. And it's really just a normal process of aging over time. And if you look at the population over the age of 50, as we get older, 50% of the population at some point will have some arthritis in the major joints in their body. And when the cartilage starts to wear away, the bones then rub against each other, really causing pain and inflammation, which can be debilitating and very uncomfortable. So this is just kind of a cartoon representation of what osteoarthritis or wear and tear arthritis is. So the diagram on the left of your screen there, a normal joint, this is a knee looking from the front, and the big bone at the top in your thigh is what's called your femur, and the big bone in the bottom is what's called your tibia. And then the surfaces of the bone are covered in what we call articular cartilage, which is this nice, smooth, spongy surface that helps form a normal gliding joint. And when you have osteoarthritis, that cartilage starts to break down, and there's defects in it that expose the underlying bone. So what happens is that cartilage wears away, and then eventually you get what we call bone-on-bone arthritis, where it's just really two rough surfaces that are rubbing against each other, which doesn't work very well and causes a lot of pain and inflammation. And then kind of the bumpy things around the knee are what called bone spurs, or the fancy word for it, or what are called osteophytes. And the osteophytes aren't really what cause the pain. The pain is caused from the deterioration of the cartilage, but the bone spurs really just kind of let us see the disease on an X-ray. And this is an X-ray of what your knee looks like. So if you think about the cartoon on the last slide, so the X-ray on the left there, again, that big bone at the top is what's called your femur, and the big bone on the bottom is what's called your tibia. And that space between the two bones, which is open and clear, is filled with all the good stuff, the cartilage, which doesn't show up on the X-ray, only the bones show up on the X-ray. And then the X-ray on the right is what an arthritic joint looks like on an X-ray. So you can see as that space wears away, those bones get closer and closer together and start to rub on each other. And then you can see some bone spurs around the joint as well. But that's what osteoarthritis is. It's just a breakdown of that cartilage over time. Other types of arthritis that we do joint replacement for, rheumatoid arthritis or inflammatory arthritis, is an autoimmune disease where the immune system basically attacks or damages normal tissue in the joint, such as cartilage, which leads to joint destruction. And eventually, just like osteoarthritis, that cartilage kind of gets eaten away to the point where it's bone on bone again and just two rough surfaces rubbing together. And typically this type of arthritis is treated by rheumatologists with different medications. And there's really been a revolution in the last 20 years or so in the development of medications to treat rheumatoid arthritis with what are called disease modifying agents. And with the development of these medications, it's been great because we really don't see the degree of deformity and arthritis that we used to see in rheumatoid patients, and it's really improved their quality of life. But these medications are typically prescribed by a rheumatologist after you're evaluated in clinic. And then other types of arthritis, what we call post-traumatic arthritis. And this is developing arthritis after you've had an injury to the knee or hip. And if you break a bone or have a meniscus tear or something like that, it can lead to down the road cartilage damage over time. And again, just like rheumatoid arthritis or osteoarthritis, eventually that cartilage breaks down and leads to the development of arthritis years after the injury. Ligament tears and meniscus injuries can cause instability as well, leading to additional wear and arthritis over time. Symptoms of arthritis that people have, generally pain will develop gradually over time, although sudden onset is also possible. A lot of times when I see patients in clinic and they see the degree of arthritis that they have on their x-ray, they'll ask questions like, why hasn't it bothered me before? And there's always a day one when it kind of starts to hurt and you can have an inflammatory episode that'll hopefully calm down over time, but you can have sudden pain as well as gradual onset. In general, the joint will be stiff and swollen, making motion more difficult during the episode of inflammation. Often pain is worse in the morning or after periods of activity. Patients will have what we call startup pain, where after they're sedentary for a period of time, they'll have pain and then they get up and move around a little bit and their pain actually gets better. That's why we encourage trying to be as active as you can in routine exercise as well as physical therapy, because keeping the joint moving as much as you can will actually help. But at the same time, it's really difficult to exercise depending on the degree of arthritis you have, and vigorous activity can cause flare-ups. At times, the joint may lock or stick during movement and make clicking or grinding noises. And that's because all that nice smooth cartilage is gone and it's really kind of two rough surfaces that are rotating over each other, and they can kind of catch and give as you move the joint. And it's also very common for patients to have a feeling of instability of their knee or hip giving out. Your knee and hip aren't going to dislocate because you have arthritis in there, but lots of patients have feelings of instability or giving out, and bracing can be helpful for that in the knee. It's a little difficult in the hip to make a brace for the hip, but it can be helpful in the knee. And then often patients will complain of increased pain with rainy or cold weather. You know, the old adage of being able to tell when a storm's coming in is actually true. Scientifically, we don't really understand why that happens, but it's a very common complaint or symptom that patients have with arthritis in their hip and their knee. Oftentimes in clinic, when you see a specialist to evaluate your joint for arthritis, typically you'll start out with an x-ray and look for things like joint space narrowing where the cartilage is wearing away, and bone spurs, and then actually a hardening of the bone underneath the worn away cartilage. The bone actually gets harder or denser because of the increased load on the bone as the cartilage wears out. And most of the time, patients have questions about, do I need an MRI? And for the diagnosis of arthritis in general, the plain X-ray will tell the whole story or give you enough information to make the diagnosis of osteo or rheumatoid arthritis. So it's generally not needed, but in special cases where the X-ray doesn't explain the degree of pain that you're having, it may be helpful to get an MRI to identify other structural problems within the joint, like a meniscus tear or a torn ligament that can also be the cause of your knee or hip pain. So this is kind of what arthritis looks like for the hip. We saw that X-ray of the knee a little bit earlier, but the X-ray on the left is a normal hip, and the X-ray on the right is an arthritic hip. So your hip's made up of your femur, the big bone up in your thigh, and then you have a ball on the end of that that fits into a socket in your pelvis. And those two help form that ball and socket joint of your hip. And if you look at the X-ray on the left, there's a space between the ball and the socket. And just like in the knee, that space is filled with all the good stuff, all that cartilage that helps form a normal, smooth, gliding joint. And if you look at the X-ray on the right, that ball is really resting on the edge of the cup. There's no space between the ball and the socket anymore. And what happens, just like in the knee, is that cartilage wears away, the space goes away, and then it's just two bones kind of grinding away on each other. And you can get bone spurs and cysts in the bone as well. But that's what hip arthritis looks like on an X-ray. So non-surgical treatment of hip and knee arthritis is pretty simple. The initial treatment is always non-surgical. Lifestyle modifications can be helpful in the early stages, minimizing aggravating activities like stairs if you can, avoiding high impact activities like running or jogging, and switching to lower impact activities like swimming or cycling. And then the other component that goes into it is also weight. The only modifiable risk factor, meaning that the only thing that you can change in your lifestyle to prevent knee arthritis from getting worse at a faster rate than it would be normally, is weight. And patients who are overweight or obese will have progressive arthritis in their knees at a faster rate than they would have normally. Physical therapy is also an option to work on range of motion and strengthening the muscles around the joint to help it function better. It can help with flexibility. And the physical therapist can help design a program for you and teach you how to do the exercises so that after you're done with your formal physical therapy, you can continue to work on those things at home after they teach you what to do. But it can be very helpful in terms of general mobility, balance, and strengthening the muscles around your arthritic joint. Other things that we prescribe and discuss in clinic quite often are using assistive devices, things like canes, walkers, or rollators. And the biggest thing that we don't want you to do is fall and do something else, like break a bone around a joint, which creates a whole nother problem. But as you get arthritis, stability gets more difficult. And as we get older, balance gets more difficult in general. And nobody likes to use canes or be seen with a walker or a rollator, but it can be very helpful and allow you to do some of your daily activities, like go to the grocery store and walk further without fatiguing. Bracing for the knee can be helpful. That picture on the right is what's called an unloader brace. It actually puts some pressure on the good part of the knee and takes some pressure off the bad part of the knee. It doesn't do anything to damage the good part of the knee, but can relieve some of the pressure where all that cartilage is gone on the part of the knee that's arthritic. Heat and ice can be helpful. Typically in the acute setting or the initial time where you have an inflammatory episode or pain, typically ice is better. And you can use it a couple times a day for 20 minutes at a time. For chronic pain, typically patients have more relief with heat over time using a heating pad. You just need to be careful because we do see a number of patients who burn themselves with heating pads falling asleep in a chair every year. So you just need to be careful. There are also over-the-counter pain relieving ointments or creams, things that are on the shelf for muscle relief that can apply a sensation of heat or mentholating sensation to the joint to help relieve some pain as well. And there's a number of different products available in the drugstore. Medications that we use to treat arthritis are also fairly standardized. Initially, Tylenol can be helpful. Tylenol is just a pain medication. It doesn't have any anti-inflammatory effect like the non-steroidals do. In Tylenol arthritis, which is available over the counter, doesn't have any additional medications in it other than Tylenol. It's just a little bit of a stronger dose and a different dosing regimen. And then typically we also prescribe NSAIDs or non-steroidal anti-inflammatory drugs like ibuprofen and naproxen, which are available both by prescription and over the counter. And then some prescription anti-inflammatories are also available, which are called COX-2 inhibitors. And these are non-steroidal anti-inflammatories that are designed to have fewer GI side effects or problems with gastritis or heartburn. Traditionally, one of the most common side effects for using anti-inflammatories or NSAIDs is having gastritis or irritation of your stomach because of increased acid production. And these medications are designed to be a little bit easier on that than the over-the-counter medications. But two of the most common ones are what's called Celebrex, or the other name for it is Celecoxib, and the other one is Mobic or Meloxicam. But it's really important to discuss with your primary care physician before starting any of these medications, because they can interact with blood pressure medications and increase your blood pressure and have some other side effects as well. So it's really important to go over your medication list with your physician who's prescribing these medications so that they can monitor it over time and make sure they're not going to interact with any of your other medications. After medications, the most common treatment are injections, and there's a number of different injection types that we use. The most common is what's called a cortisone injection, where we inject a corticosteroid into the joint itself. And these are powerful anti-inflammatory agents which try and decrease the inflammation in the joint, which is what causes the pain. There is a question in terms of some research or data that you can actually have further cartilage damage to the joint because of the medication that we're injecting. But most of the time we use these injections in patients who are already moderately to severely arthritic, so that they've already had cartilage damage and it's not an issue. You can repeat these injections typically 3 to 4 times a year. Depending on the results and how much relief you get from them. Common side effects from these injections can be some facial flushing, and you can also have a temporary increased amount of pain in the joint for 24 to 48 hours after the injection before the anti-inflammatory agents really kick in. But it's a very common treatment and injection that we give many times in clinic a day. The other main type of injection that's on the market is what's called viscosupplementation, is the fancy word for it. There's a number of common terms for it as well, what people call gel shots. They also call them chicken shots as well, because the molecule that's in the injection was actually engineered from the comb of a rooster. And it's the same molecule that humans have in their joint fluid. A common misconception with these injections is that these injections work to replace cartilage in the joint, which isn't true. These injections just help improve the quality of the fluid in the joint, which we all have in our joint, and helps form a normal gliding joint. So it really just helps restore some of the fluid quality and make the joint glide a little bit better. But just like cortisone, the effects are limited and it wears off over time. Typically, you can repeat gel shots or viscosupplementation. Your insurance company typically will only cover it every 6 months. Other medications or supplements that are on the market, glucosamine and chondroitin, are two things that are found naturally in joint cartilage. And these are sold over the counter in drugstores and in nutritional supplement stores, and as dietary supplements. These are not regulated by the FDA, and dosage in what's in them from different brands is really not known. And although patients take these supplements and say that they make their joints feel better, scientifically, there's no evidence that they make any difference at all. You're not going to hurt yourself by taking them. I just can't scientifically tell you what they're doing. And they can interfere with other medications, including blood thinners in patients who are on Coumadin. So you just want to talk to your doctor and make sure they know you're taking them before you start them. So who is a candidate for joint replacement? So after all these conservative and non-surgical treatments are no longer working, and really your joint pain is interfering with your quality of life and you're no longer able to do your daily activities. I tell my patients a lot, if you're waking up every day saying, I really need to do something about this, that it's really time to start thinking about surgery, as long as the indications for the surgery are there. Our most common age group for joint replacement are patients between the age of 60 or 80, but joint replacement isn't confined to this age group. We do joint replacement in patients who are under the age of 60 and over the age of 80 all the time. And we do joint replacement for specific reasons in even younger patients in their 20s and teens who have birth defects or have had other treatments that cause arthritis at an earlier age. I think the oldest patient that I've ever replaced a hip in was a gentleman who was actually 102 and was actually still driving his car back and forth to New York City on a monthly basis. So age is always relative. Not every 80-year-old is the same and not every 60-year-old is the same. There's a lot of things that go into the decision-making process. So again, pain that limits daily activities. Chronic medical conditions need to be under control. The most common ones we deal with are diabetes. So patients who have uncontrolled diabetes are at higher risk of infection and wound healing problems at the time of the surgery. So if your diabetes is out of control, when we look at your labs preoperatively, we'll ask you to follow up with your primary care physician so they can get your blood sugar under better chronic control to limit your risk of complication. Weight loss plays into it as well in terms of being a candidate for surgery. And the way we typically look at weight for joint replacement is what's called your BMI, which is a ratio between your height and your weight. And currently, we would really like that BMI to be under 40. And there's really specific reasons for this. There's very good data that shows that once you hit a BMI of 40, there's a much higher rate of infection, wound healing problems, and the joint replacement failing earlier than it should. So it's very important to counsel patients, and we may refer you to the comprehensive medical weight loss program at UH that also can discuss surgical options for your weight loss. Limited mobility is a common complaint as well. And once you're having difficulty doing things like putting on your shoes and socks or getting up from a seated position or going up and down stairs, it's probably time to start thinking about discussing joint replacement with a surgeon or getting a referral to a specialist so they can evaluate you. So people often ask what to expect in terms of the whole process. There's a number of different ways where you can approach somebody about discussing joint replacement surgery. Oftentimes we get referrals from your primary care physician once it's time to start thinking about surgery, but it's completely appropriate to make a direct appointment with a specialist, and we'll have a phone number at the end of the talk that you can call to do that. But anytime you have any concerns, we're happy to see you and kind of talk through the process and see if it's appropriate to start thinking about surgery. But again, your surgeon will examine you and take x-rays and take a history and determine if you're a candidate for joint replacement. Average hospital stay for a joint replacement has decreased over time. Even 10 to 15 years ago, on average, patients would spend 4 nights in the hospital before they would go home. and oftentimes spend some time in a rehabilitation facility for their recovery afterwards. And that's not really the norm anymore. Our average hospital stay for both hip and knee replacement is really only one night in the hospital, and patients will go home the morning or the afternoon next day and have physical therapy in the comfort of their home, and be able to monitor their wound and change their dressings and things like that. Within the last couple of years, we're really moving towards outpatient total joint replacement. And probably within the next 5 years, 50% of the joint replacements, both hip and knee in this country, will be performed in an outpatient setting, either at a hospital where you're discharged the same day, or an ambulatory surgery center where you go and have surgery and are discharged from the ambulatory surgery center without ever having to be in a hospital. But this is really where the field is headed in terms of recovery. There's a lot of things we do differently these days in terms of pain management and rapid rehabilitation, as well as different surgical techniques to help with that. It's really important to remember that recovery takes time and everyone is different. You should work closely with your care navigator, your surgeon, and your primary care physician to develop really realistic goals for your surgery and what you want to get out of it. We answer a lot of questions in clinic where people have talked to their friend who've had a knee replacement or a friend who's had a hip replacement and what their expectations are. And it's important to remember that your journey is going to be different than everybody else. And a lot of things go into it in terms of your health, the shape you're in coming into the surgery, the degree of arthritis or deformity you have at the time of the surgery, which can all affect how long it takes you to recover. I tell patients in general that after both hip and knee replacement, the first 3 weeks are really the most difficult part, where you're really getting over kind of the acute pain from the surgery. But to fully recover for both, to really get to the point where you're not thinking about it anymore and you kind of own the joint. So at the end of the day, you're thinking, man, I forgot about the fact that I had hip or knee surgery this year. It's really realistically about 6 months. You're not in pain for that whole period of time, but to really get to the point where you own it, it takes some time. The other thing is to be careful of the internet in terms of the information that you get. We spend a lot of time in clinic kind of re-educating patients about things that they read on the internet. And there's just a lot of misinformation and misleading statements on the internet. But you should really discuss all of those things with your surgeon, who can really give you evidence-based answers to what the treatment options are and what the expectations and outcomes are. And everybody always asks kind of what a hip replacement or a knee replacement looks like. So this is the X-ray that we showed earlier of that arthritic hip on the left. And this is a post-operative X-ray of their hip replacement on the right. So there's a couple different parts that a hip replacement's made up of. And you can see how there's a metal stem. This is made out of titanium. All hip replacements are really made out of titanium. And that metal stem goes into your bone, and it's coated with a special material that your bone grows into over time. And the stem looks really large on the X-ray, and everybody asks how big it is, but it's really only about 4 to 5 inches long, and it looks like it goes a long way down your leg, but it really doesn't. And the other component is the cup part that we also replace as well. And that cup is also made out of metal and coated with a special material that your bone grows into over time. And oftentimes we'll use a couple screws to hold that cup in place while your bone grows into it. And then we give you a new ball to replace the ball that you had before. And then there's actually a piece of plastic that fits into the cup that helps form the normal joint. But that's what a hip replacement looks like on your X-ray after the surgery. And this is what, we'll go back here, sorry about that. And this is what a knee replacement looks like. So there's that arthritic knee on the right with the loss of the joint space and the bone rubbing on the bone. And this is what a knee replacement looks like after the surgery. And everybody thinks we remove a large portion of your joint at the time of the surgery, but you only really remove about 9 millimeters of bone on either side of the joint. And there's basically a metal cap that goes over each end of the joint, and those are either cemented into place or have a coating on the back of them that your bone grows into. And then there's a piece of plastic that goes in between the two that helps form the new gliding joint. But that's what a knee replacement looks like if you've never seen one before. That's about all I have in terms of the presentation, but we're happy to take questions and we'll answer them the best that we can.
Okay, great. Excellent information. And we have a ton of questions. So I will
Great.
start with a question from Barb.
Okay.
My knee makes crunching sounds like Rice Krispies, particularly when I ascend stairs. Would gel or cortisone shots help? She says that she doesn't know if she's ready for surgery yet. There is some pain, but it's minor.
Yeah, so the main indication to have your joint replaced or start thinking about surgery is for pain. So it's very common for patients to have arthritis for that joint to make noises or crunching sounds. Even my knees at this point, when I get up from our crouch position, go snap, crackle, pop. But some of that can be arthritis under the kneecap, which is common going up and down stairs to make noises. And the reason it does it again is because all that cartilage is gone and they're not two smooth surfaces that glide over each other. So they're kind of rough and they kind of catch and give and make grinding and popping noises. In terms of the injections making the grinding or popping noises go away, most likely they won't. The joint can still make noise. The real reason to get the injections is to relieve pain.
Great, thank you. Next question comes from Sharon. Is it safe to have a hip replacement in a 71-year-old male that has his EKG showing left anterior fascicular block?
The easy answer is yes. We treat patients who have cardiac issues all the time with joint replacement. Those patients would be evaluated preoperatively by a cardiologist, and you would have some cardiac testing to make sure it's safe for you to undergo the surgery. So if there was something that was modifiable in terms of your risk for the surgery that your cardiologist could do in terms of a stent that would need to be placed or something that they can do in terms of a medication to decrease your risk prior to the surgery, we would have you evaluated by cardiology. But most patients whose chronic medical issues are manageable can still be a candidate for total joint replacement.
Excellent. Next question is from Paul. I understand steroid injections can damage cartilage. If it is damaged, is it only at the injection site or at other joints?
That's a good question. So when you have an injection in your joint, the cartilage damage from the injection, and again, we try and, if your joint still had good cartilage in it, we would delay injections. But most of the injections that we give are patients whose cartilage is well on its way to having defects in it to begin with. But that injection only acts locally within the joint that is injected. So it's not like if you have a steroid injection in your knee, it can affect your shoulder. It just stays locally within the joint that's injected.
Okay. Next question is from John. Is it possible to have an allergic reaction to the knee implant if you have a nickel allergy?
So nickel allergies or metal allergies in terms of joint replacement is incredibly controversial. So there are patients who can have allergies to metal. Most of the time you would know that you have an allergy to metal just from going through life in terms of wearing jewelry or a watch. And the most common one is having an allergy to nickel. There is some testing that can be done preoperatively, although it's not 100%. So there's kind of two things that can happen. You can go to an allergist to have skin testing done for different metals that are used in joint replacement, but it's not certain whether skin testing correlates to you having a reaction to the metal prosthesis in you. So there are plenty of patients who have cutaneous or skin reactions to metal who don't have a reaction to an implanted metal device. But there are implants on the market that either have no or very low levels of nickel that we use in patients who have metal allergies to help get them through their joint replacement and get them back to life.
Thank you. Question from Carrie. Do you do knee replacements for floating patellas? And then also, my knee is very painful and swollen when I get cortisone shots every few months. Would I be qualified for a knee replacement?
Yeah, so it's hard for me to understand exactly what you mean by a floating patella. So if you have, patellar instability or a patella that can dislocate or move out of the joint, that's kind of a separate problem than arthritis. But there are some things you can do surgically to fix that problem as well. The main reasons to do the joint replacement is for arthritis. So we'd have to look at your x-rays and look at the problem to see if you're a candidate. Um, in terms of the reaction after the injection, it's not uncommon, but it's not common. So patients can have an initial flare after their injection where they have a period of pain that settles down over time as the injection begins to work, but it can happen. And there are patients who can have allergies to the steroid that you're injecting, which is rare, but it does happen.
Great. This next question is from Nicholas about bilateral knee replacement. In the case of needing both knees replaced, is there ever a situation where they would be done at the same time? And would they be done separately? And roughly what would the timing be between them?
Sure. So this is also a common question in the world of knee replacement, is also incredibly controversial. I stopped doing bilateral knee replacements about 7 years ago for a number of reasons. There is some data in terms of studies of an increased complication rate in terms of infection. And there's also some question of whether there's an increased risk of having a heart or lung event, so a cardiopulmonary event at the time of the surgery. The other reason is that the rehab is incredibly difficult, and a lot of those patients will have to go to a rehab facility afterwards before it's safe for them to go home, which also brings into question a higher infection rate going to a facility instead of going to your home. So I stopped doing it a while ago. There still are surgeons in the area that definitely do it. It's just, in my opinion, not in your best interest. The fastest I can typically turn a patient around in terms of getting them rehab successfully to come back and do the other knee is 6 weeks. And there's lots of patients that choose to do it that way. And there's lots of patients who don't, that they want to spread it out. But that's the fastest typically that I'll rehab you and bring you back to do the other side if you need it.
Okay. Next question is from Dar. This is in reference to the slide where you showed the brace. The comment is, this kind of brace is excruciating for me. They're dealing with an unrepaired ACL rupture from 1977. Question is, what can I use to support lateral movement without causing too much pressure?
Yeah, so I mean, braces are tough. Braces are tough, one to fit. So you want to make sure that you get a brace from somebody who's proficient at fitting you for the right size and the right type of brace. The brace that you have may not be the right type of brace for your issue, which we see all the time. And then braces are uncomfortable for a lot of patients. They do cause pressure on different parts of the joint. And can cause skin irritation and other things. And there may not be a perfect brace for the condition that you have. But I would just make sure that whoever's providing the brace for you, definitely has a good fit. There's custom braces available versus just off the shelf braces. But yeah, patients do complain about issues with braces. They're not perfect and can cause pain in other parts of the leg or the joint that it's immobilizing. But if the brace isn't working for you, you probably need to start to discuss other options other than just bracing.
Great. Next question is from Richard. I've had 3 cortisone injections in my knee. The last one didn't provide much relief. What's next?
Yeah, so typically it's pretty common. Patients will typically kind of have diminishing returns from their cortisone injections over time. And part of it, we don't know why, but part of it's just the progression of the arthritis over time, but they tend to work less and less. So, like I talked about a little bit earlier, there are other injections, what are called gel shots or viscosupplementation. We'd have to look at the degree of arthritis that you have. There's very good data that shows that patients who have really bad arthritis or end-stage arthritis in their knee, the chance of the gel injections working is very, very small. But if the conservative treatment isn't working in terms of the injections and you have arthritis that would qualify you for a joint replacement, it's probably time to start thinking about doing something.
Great. Next question is from Barb. What type of doctor do I need to see to be able to try Mobic or other non-surgical options?
Yeah, so there's actually a number of different options. One, you can start with your primary care physician, who's able to get x-rays and take a look and if you have arthritis. So they're perfectly capable of prescribing anti-inflammatory medications like Mobic, as long as you don't have any other medical conditions or contraindications for taking those medications. But your primary care physician is an option. And then your surgeon can also prescribe those medications. But there's also other options in terms of pain management specialists who can help you with that, as well as physical medicine and rehab physicians who we have great ones here at UH who can discuss non-operative treatment with you as well. So there's actually a number of different sources that you can get those medications from, and who you choose to start with is completely up to you, and all of them are appropriate, and we're happy to see you as a surgeon anytime. But if you're not ready for surgery, we may direct you to another provider, either your primary care physician or somebody else who can monitor those things for you until you're ready for surgery.
Thank you. Next question is from Sarika. For torn meniscus, is orthoscopic surgery a better option? And what are the advantages and disadvantages of this procedure?
Sure. So there's people who have torn meniscuses at multiple different stages in life. So arthroscopic surgery for a torn meniscus, if you don't have arthritis in the joint, can be very successful. So patients who don't have an arthritic joint and have a torn meniscus from a sports injury or something else, and are having what we call mechanical symptoms in their knee, meaning that their knee locks or catches on them, arthroscopic surgery can be a great option in terms of helping with that. The hard part is patients who already have an arthritic knee and also have a meniscus tear, what we call a degenerative tear of their meniscus. And that's really a mixed bag. So a lot of patients who have an arthroscopic procedure for their meniscus in the setting of arthritis, there's a number of those patients who will be, worse after that operation than they were before. So you want to be very careful in terms of discussing what the risks and benefits are with your surgeon. And there's patients who are kind of in a gray zone where, arthroscopy is not a great option for them, but they're not really ready for joint replacement either. So there's options out there, but it just depends on the setting of the meniscus tear, what type of meniscus tear it is, and what else is going on in the joint at the time, whether or not you would be a candidate for an arthroscopic procedure.
Great. Next question. I'm in serious need of a knee replacement, but I have a horrible allergy to titanium. What are my other options?
Yeah, well, the good news is most knee replacements aren't actually made out of titanium. So most knee replacements are made out of what's called cobalt chrome. So patients who have a nickel allergy, which is in cobalt chrome, can have issues with knee replacement, but patients who have a titanium allergy shouldn't have an issue with a standard knee replacement because it's not made out of titanium. Hip replacements are made out of titanium, but most knees are not.
Great. Next question, two-part question from Sue. The first part is, can acupuncture help with hip arthritis?
So acupuncture can be a great adjunct to your treatment prior to surgery. So it's not going to make the arthritis go away, but can help with pain around the joint or pain caused by the arthritis. I mean, it's actually something we use in the hospital after surgery. I started an acupuncture program after hip and knee replacement at Ahuja. So while patients are in the hospital, they actually get acupuncture post-operatively to help with their pain. But it is a great modality to use preoperatively as well in your arsenal to help with your pain prior to surgery. The hard part is a lot of times insurance won't cover it, so there's out-of-pocket costs associated with that. But the Connor Integrative Institute at UH has a number of acupuncturists who could give you great advice on how to proceed with that if you had questions.
Thank you. And the second part of the question is, what do you think of muscle sparing hip replacement?
So all hip replacement, so this is a common question that we get, that all hip replacement today is really muscle sparing. There's nothing that we do today that wouldn't be classified as minimally invasive to compared to what we were doing even 10 years ago. And traditionally there's 4 different ways, or well, 4 or 5 different ways to get into the hip. There's what's called a direct anterior approach. There's what's called a anterolateral approach. There's a lateral approach. There's a posterior lateral approach, and there's even a superior approach. In the direct anterior approach, which is advertised most commonly now as the latest and the greatest, is actually not new at all. It's been around for 20 years. And there's no great data that shows that any one of those approaches is really any better than any of the other approaches. They all have their pluses and minuses and unique risks and benefits associated with them. The only thing that really shows up in study after study that really makes a difference in terms of success of the surgery and recovery is the volume of the surgeon that does it. So you really want to go to somebody who does a lot of these procedures. I'll often use the analogy of getting on a plane. You don't want to get on a plane with the guy who just got his pilot license yesterday. You want to go to the guy who's got 1,000 hours in the air before you're flying with them, if that makes sense.
Absolutely. Can you tell us, as a surgeon, the total number of joint replacements you do over the course of a year?
Yeah, so between hips and knees, I do somewhere on an average year between 400 and 500 a year.
Thank you. This is a good question from Earl. Why is there not any engineered replacements for knee cartilage?
So that's a great question. There's lots of people working on it. The hard part is that cartilage is a very complex structure. And physically, it has to be strong in both shear and compression. And there's a lot of different components that go into it. We can make shapes and different things that are close to cartilage, but nothing with the structural properties of what you were born with. So there's, obviously the interest in all of us would not to be to replace the joint and be able to replace cartilage. But the technology is just not there yet. And I don't see it really happening anytime in the near future. It's just a very complex problem to solve biologically. Stem cell therapy is very popular right now because it's a cash business. So it's not covered by insurance. It can be anywhere between $500 to $1,000 an injection. There's no evidence that shows that it can reproduce or make new cartilage. And there's a lot of controversy right now of companies being even prosecuted for false claims about stem cell therapy. So I'd be really careful and educate yourself before going down that road as well. But hopefully someday the technology will get there and we can inject some cells into the joint and make new cartilage. Just not there yet.
Great. This is probably a really common question. It comes from Anne. I live alone. What are the requirements for leaving the hospital after you've had hip replacement?
Yeah, so living alone, obviously, we're very cognizant of the fact that not everybody has a home structure where they'll be able to go home. But we really even ask that if you have friends or family around who can stay with you a little bit, recovering in home is really a lot better than going to a rehab facility in terms of your recovery, in terms of comfort, cleanliness, risk of infection. So we really try and get you home if we can. But you're going to need some help. You don't necessarily need 24-hour care, but you're definitely going to need some help to do your daily activities, get meals, things like that. Physical therapy will come to the house initially, but you're not going to have 24-hour care provided by your insurance company. You can pay out of pocket sometimes for a home health aide to be there, but rarely your insurance company will cover that. But in general, your requirements to get out of the hospital and be safe to go home will be evaluated with a physical therapist while you're in the hospital. So you'll have a walking test. You'll go up and down stairs at the hospital before you leave the hospital. And they'll discuss your home environment with you to make sure it's as safe as we can make it for you to go home. And if absolutely you have to go somewhere to recover, then you will go to a rehab facility after your surgery. But we really try and avoid that these days.
Thank you. The next question is from Mary Lou. If you have arthritis in your spine and hips, how can you tell which to treat and or replace?
Yeah, so this is a really common issue that comes up because it's very common for patients who have hip arthritis to also have spine arthritis. So we work very closely with our spine colleagues in orthopedics to determine which is the most pressing issue. And there's no perfect answer in terms of what should be fixed first in terms of your hip or your knee. A lot of times it's just personal preference from the surgeon and what they want to do. But obviously, if you have spine issues where they're getting so bad where you can't walk, or there's a risk of progression in the future of muscle weakness and things like that, spine issues can become the more pressing issue. And there's also a risk of increased risk of dislocation of a hip replacement in patients who've had spinal fusions in the past. So that's also something to consider, but we have tricks and different devices we can use in the operating room to help prevent that. But it's very common. And I would just say that you need to work closely with your surgeon and your spine surgeon so they can have a discussion of what your issues are and determine what the most pressing issue is for you and what you should tackle first. But there's no perfect answer.
Great. This question comes from Nancy. I know people who say they've had their knees cleaned out. What does this entail?
Yeah, so there are surgeons who will do an arthroscopy for arthritis. And this is incredibly controversial. You can't fix arthritis with a scope or an arthroscopy. So, excuse me. Typically, in what people describe as a clean out, they'll go in and shave down some of the roughened cartilage to make the joint glide more smoothly. But there's a number of patients who after that procedure will progress to have arthritis at a more rapid rate than they would have normally. So you have to be really careful about the indications for arthroscopy, and in general, arthroscopy for arthritis isn't a great solution.
Okay, next question. I heard cortisone shots given 3 to 4 times could damage the knee permanently. Is this true?
Yeah, so we kind of covered this one a little bit earlier. So there is some evidence that some of the medications we use in cortisone injections can damage cartilage, which is why we try and reserve injections for patients who already have damaged cartilage. And once you have damaged cartilage, it's damaged. Your body doesn't reproduce it or regrow it, which is why eventually you need a joint replaced. But your surgeon or your practitioner can help advise you that, or advise you on that in terms of the degree of your arthritis and whether injections are an option for you. But it's not, there's a lot of misconceptions about cortisone injections that if you have the injections or start on the injections, that you have to continue them or they're going to completely destroy your joint. It's just not true.
Next question. My doctor suggested an osteotomy knee surgery. Is that the same as partial knee replacement?
It isn't. So in patients who have mild arthritis or a deformity in their leg, which makes them more prone to developing arthritis, you can actually undergo what's called an osteotomy, where you cut the bone and then realign it and then have it heal in a different position to take some pressure off of the areas where you're going to develop arthritis over time. And it is an option for patients typically who are younger, who have very early arthritis. It's not an option once you have moderate to advanced arthritis in terms of an osteotomy. Partial knee replacement is different, where you just replace part of the knee that's damaged, and whether or not you're a candidate for that versus a total knee replacement would have to be assessed by the surgeon and taking a look at your x-rays and your other studies.
Thank you. This question comes from Cheryl. Does wearing a brace weaken the knee more?
It doesn't. So that's a very common question we get in clinic. So braces are great at helping with stability, but by wearing a brace, it doesn't compensate for your own muscle strength and doesn't cause your leg to be weaker over time. Common misconception, but it doesn't work that way.
Great. This question comes from Penelope. Could you please mention the relief that Salonpas gives? And then the second part of that, why don't you answer that, and then I'll read the second part.
Yeah, Salon, but I have to look what's in Salonpas. Again, lots of patients use it. I can't remember the actual ingredients for Salonpas, but it's available over the counter. It's another pain relieving option. It's not something that's prescribed by a physician, so it's kind of similar to an ointment or something like that you would get at the drugstore.
Great. And the second part was basically Penelope said that she has used all over the counter pain relievers for her 4 years of RA and now OA. And she said that for her, the Salonpas patches are a godsend. So.
Yeah, it's great. Lots of patients use them and love them. It's not something that we prescribe, but it's not going to hurt you to use them. And if that's what worked for you, that's great.
Great. This question is from Eva. Do I need to go through my primary care physician and get referred to you, or can I contact your office directly?
So you can either do it either way. So you can either go through your primary care physician and get a referral, but you do not need a referral to come see us. And the appointment line is there on the screen in terms of making a direct appointment to come see us. We're happy to see you anytime. Yes,
for anyone who would like to see Dr. Fitzgerald or another orthopedic provider that may be closer to your home, just call 216-243-2028. That is our main scheduling line for orthopedics. And again, if you want to see Dr. Fitzgerald, they'll help you make that appointment or any other orthopedic provider. So let me see. This question comes from Kim. Is there any evidence for using an infrared light for pain relief, or does it help in any other way?
Say that one more time. You broke up for just a second. I couldn't hear.
Is there any evidence of using an infrared light to help deal with pain?
Yeah, I'm not sure I'm the best person to answer that question. There's a number of different things that are out there in terms of alternative pain relieving methods. I have no experience with infrared light, and I'm not aware of any large population-based studies that have any evidence that it makes any difference. But I can look into that and get back to you if you have the question, but I really don't have any experience with it.
Okay, fair enough. This question is horseback riding an A-OK after knee replacement, and how long after surgery can I resume riding?
Yeah, so the first part of the question, for sure, you can ride a horse. I have plenty of patients that do it all the time. It's what they love. Horse people are very passionate about it, and that's part of the goal of doing the surgery, to get you back to doing the things you love. The timing is different for everybody, so everybody's journey after surgery is a little bit different. So there's no set mark that says you can ride a horse at 4 weeks or 8 weeks. You just need to have the discussion with your physician in terms of your own individual recovery. But yeah, the goal would be to get you back to doing the things you want to do.
Great. We have about a minute left. Would you mind taking about an extra 5 minutes to finish these questions?
Yeah, no problem. Yeah, no problem.
Great. Okay. Thank you, Dr. Fitzgerald. The next question, do you use staples or glue in knee replacements, and why?
So I don't use staples. So the way that I close a wound is everything's under the skin. You have nothing that needs to be removed. You have a dressing that you can shower with immediately after the surgery. But no staples. I don't think the scar looks very good, and there's a questionable higher risk of superficial infection using staples. So that's why I don't use them.
Great. Let's see. Based on a previous question, how do you know if you have an allergy to titanium or any other metal used in hip and knee replacement?
Yeah, so typically you would know. Because of contact, all of these metals are very common in many household items and jewelry and watches and clothes. So if you had a metal allergy, most patients are aware of that. But there are patients who have unexplained pain after joint replacement that theoretically could be due to metal allergy, but it's incredibly rare and very difficult to test for. So the good news is that most patients know ahead of time that they have an allergy to metal and can discuss that with their surgeon ahead of time.
Great. Let's see. This question is from Monica. My 82-year-old mom had osteoarthritis in the left hip and left knee.
Mhm.
Her main complaint is pain in the left quadriceps as opposed to direct pain in the joints. She
Mhm.
takes Mobic and is sedentary inactivity, which I know doesn't help. What
Mhm.
things may help with the muscle pain?
So number one, it may not be muscle pain. It's very common to have referred pain in the thigh or the knee because of the hip arthritis. Um, so it's very common for patients to come into clinic when with actually isolated knee pain, for example, when the problem is actually their hip. So it's very common to have referred pain. So it would be important to see a practitioner in terms of trying to figure out exactly what's going on, because it may not be muscle pain. It may just be pain from the arthritis itself. And there's different treatment options for that. In terms of if it is actual muscle pain, it's typically medications like anti-inflammatories and physical therapy.
Great. This question is from Cheryl, and you touched on this a little bit earlier, but we had a friend that said PRP injections worked very well for them. What are your thoughts?
So PRP is also controversial in terms of a biological injection where they take a component of your blood and remove it and then inject it back into the joint. The evidence is pretty mixed, definitely in patients who have a moderate to advanced arthritis in their joint. It's not going to make the arthritis go away. And it's just like everything else, it's temporary in terms of the pain relief. There are patients who have PRP injections and who love it. And there's patients who it doesn't work at all. So I would just kind of, talk to your practitioner about the risks and benefits of doing those types of injections, what your out-of-pocket costs in terms of your insurance will be, because a lot of times insurance won't cover PRP injections. And you just want to make sure it's the right treatment for you and you're going to get the benefit out of it that you want to.
Great. And we are down to our last question. They're stating 15 years knee bone on bone. I am scared of surgery. I'm trying to lose weight, walking 2.5 miles a day. Why is it so incredibly painful to walk? And why painful while walking and after?
Yeah, so the pain's caused by inflammation because of the arthritis. So as you walk, those two bones that don't have any smooth cartilage over them anymore rub together and cause pain. That's the hard part with arthritis. In terms of being scared in terms of surgery, it's perfectly reasonable to be scared of surgery. It's surgery. There's a lot of things that can happen. The good thing about joint replacement is that it's one of the most successful operations that we have in all of surgery. So the chances of you having a good outcome or a great outcome are very high. But it's perfectly normal to be scared of having surgery, and it would be great for you to talk to a surgeon who you connect with, who can talk you through it and answer the questions that you have. But the pain with activity is very common. It's just not a normal joint anymore, and that's the hard part about arthritis, that we want you to be active, but at times activity can cause pain.
Great. Well, thank you, Dr. Fitzgerald, for your time and sharing this very important information. Obviously, arthritis and osteoarthritis affects millions of people, and this information has been very helpful. And to all of our participants, thank you for your questions. And of course, Dr. Fitzgerald, thank you for sharing your expertise, advice, and direction with the questions we received. So a couple of reminders for the audience. Again, we will be emailing you a link, so you'll be able to view this session again. You'll hear the entire presentation along with the question and answer session. You'll also know that this will be placed on the University Hospital's website. We have a library of all of our virtual talks, and they can be found at uhhospitals.org/health-talks. So if you're interested in learning more or looking into other topics that we've discussed, that would be great. Again, to make an appointment with Dr. Fitzgerald, you can call 216-243-2028. For more information on our website, anything in regards to orthopedics, uhhospitals.org/ortho. So again, thank you so much for everyone for attending, and this concludes this evening's event. We hope you'll join us for future talks and have a pleasant evening. Thank you.